Good evening, students. So, welcome to Radiation Oncology course. I am Dr. Ganesh Kumar Patel, medical physicist and radiological safety officer working in Department of Radiotherapy and Radiation Medicine, IMS BHU. This is in continuation with lecture 26 and the present lecture is the lecture 27. The lecture's topic is intensity modulation radiation therapy. So, before continuing with intensity modulation radiation therapy, modulated radiotherapy, we must understand what we have in short, what we have understand in the previous lecture. In previous lecture, we understand the 3D conformal radiotherapy technique, which is a little advanced form of a conventional technique, and 3D CRT technique is generally delivered by a linear accelerator machine. Now we are going to understand a more advanced technique, which is a revolutionary difference or is a marginal difference between a 3D CRT technique and IMRT technique. IMRT technique is an advanced technique which is based on the basic form is from 3D conformal radiotherapy. It is a non-uniform intensity of the radiation beam. Variable radiation intensity is generated across each beam in contrast to uniform intensity used in 3D CRT techniques. Each beam is subdivided into hundreds of beamlets, each with an individual intensity level, enabling a very complex pattern to be constructed. Because of this high degree of conformity and OR sparing can be achieved. It is a CT based planning and generally CT images with 3 mm slice thickness recommended. IMRT is also known as inverse planning. Here objectives are achieved first before the dose distribution before we found the dose distribution. So 3D CRT, I said that it is a forward planning technique and IMRT is a inverse planning technique. In 3D CRT the slice thickness of 5 mm is recommended, but in IMRT the slice thickness of 3 mm is recommended. So now you can look at the figure. What we have seen in 3D CRT technique, when a 3D CRT technique is planned with its 3 fields, you were able to confirm the target and spare the OARs, spare the normal tissues, but difficult to spare the organ at a risk. But when you are switching to intensity modulation technique, your conformity is highly improved and your OR sparing is well achieved by the intensity modulated technique. So now you can see that this OR, if suppose this is a spinal cord, it is well saved by the intensity modulated technique. Now if you will look at this figure, this is the diagram of an intensity by 3 different gantry angles. You can see that the intensity is not uniform. In this case, your intensity is almost uniform by all the 3 fields. So you get a homogeneous dose distribution in 3D CRT technique. But in case of IMRT technique, your intensity is not uniform. It is varying. It is varying according to the target and according to the OAR which is to be sparing. So what is the logic of intensity modulation? What it changes from 3D CRT technique, we will discuss in further slides, but before that we understand what are the advantages of IMRT technique. As I said, it has an improved target conformity, which you can see in the figure, particularly for concave target volumes, can produce intentional dose inhomogeneity or dose bending. I said you that as against the 3D CRT technique, where you will get a homogeneous dose distribution, in IMRT you can intentionally obtain an inhomogeneous dose distribution. It means that where you require a higher dose, you can achieve a higher dose. Where you require a lower dose, you can achieve a lower dose. Therefore, because of this, there is an increase of normal tissue sparing, enabling the dose escalation. You can go for higher dose for better curative intent. So which directly benefit the therapeutic gain. But there are some few disadvantages of IMRT. It increases a clinician time for target and OR contouring. Because it is a little complex technique, there is a more planning duration is there, so which we will discuss further. Needs extensive quality assurance program, higher integral dose which can increase probability of secondary cancer. So the main disadvantage which I understand from IMRT is the integral dose. The integral dose in IMRT is little higher, or say marginally higher as compared to 3D CRT, and which is a little concern. So how the workflow in IMRT planning? The goal is same which we discuss in 3D CRT technique. We have to achieve a maximum target coverage or PTV coverage 95% or 98% of the prescribed dose to means 100% of prescribed dose should receive 95% or 100% of PTV volume, and to limit the OAR dose as per the dose constant and depends upon the treatment site. The first step, which already discussed in previous lectures, GTV, CTV, PTV. After target delineation, there is a dose prescription and planning goals, selection of number of beams and optimized beam angles. This is also same which we discussed in 3D CRT. Objectives are achieved by process of optimization. This process differs from 3D CRT. Objectives are achieved by process of optimization. The process of optimization is a computer controlled process, and it is totally based on the optimization algorithm. It is an dedicated program written for this process of optimization, which we will discuss in next slides. Once the desired objectives has been achieved, the dose calculation needs to be performed, and once the dose calculation is performed, you can see the dose distribution and will go for the plan evaluation and plan approval. So IMRT treatment delivery has a common two methods of treatment delivery. One is the segmental MLC or step and shoot IMRT. What is segmental MLCs? This method has evolved directly from conventional radiotherapy. For each beam orientation, several different MLC shaped field segments are created. A modulated field intensity is achieved by summing all the segments. The radiation is only turned on when the segments are in position, and thus this method is known as step and shoot. This is now available from most linear accelerator manufacturer and is likely become the most widely implemented technique. So in short, a step and shoot delivery technique is that in this multi-leaf collimator forms a segment, takes the shape of a segment, beam. Once the MLC takes the shape of a segment, beam on, and going to the next segment, beam getting off. What is dynamic MLC? In contrast with dynamic MLC, the MLC leaves are continuous motion during treatment of each field. At a fixed beam angle, each pair of opposing MLC leaves is swept across the target volume under computer control to produce the desired fluence profile. Variation of the speed and distance between the leaf drives our desired intensity of radiation to the specified point. This can produce more conformal dose distribution than segmental IMRT and is therefore more desirable for complex problems. So the term dynamics means there is a continuous movement or continuous motion of a multi-leaf collimator while the beam is on. In short, this is the meaning. In the figures, we will understand these techniques in detail. First, we understand what is the intensity modulation, how the intensity modulation is achieved. What is meant by intensity? Intensity is nothing but means by photon fluence, because we are going to treat the patient with X-rays. X-ray consists of photons, and the number of photons passing per unit area, we call that as a photon fluence, and this photon fluence known as an intensity of a beam. The very important thing is that in intensity modulation, we are varying we are modulating the photon fluence. We are not changing the beam energy. It means that the treatment energy is not going to change. If you are treating the patient with 6 MV beam energy, the energy will remain 6 MV. The photon fluence will change, means intensity will change. The beam profile coming from a linear accelerator is a flat beam profile, and it is modified by movement of MLC. Now look at the figure. This is a MLC from bank A, bank B. This is from bank A MLC, bank B MLC. Your radiation beam, which is nothing but your photon flux or photon fluence. Now when you're interested the photon fluence, your beam profile is like a flat. This is a flat beam profile, flat beam profile. This is your actual beam profile before the MLCs. How this flat beam profile becomes like this? This is the modulated beam profile. How? The process of modulation is possible with the variation in the speed of MLCs and the movement of MLCs. An MLC leaf pair moving across the radiation field with varying speed and leaf gap openings form a modulation. Radiation intensity profile created along the path of the travel of MLC leaf pair, and this is the intensity map. This is the intensity map. So in short, I will tell you that the speed of MLCs and the movement of MLCs decide the modulation degree, and your beam profile gets modified accordingly, which you can see at this figure. Now I have said that there are two ways of IMRT treatment delivery. One is static field treatment, or static simply segmental IMRT. In what happened in segmental IMRT, suppose this is our treatment area. This area is being treated by three fields, 1, 2, 3. Now these three fields, in each field, suppose this field 1, MLC forms three segments, 1, 2, 3. So in field 1 MLC have a 3 segments, in field 2 MLC have a 3 segments, and in field 3 MLC have a 3 segment. So in case of step and shoot IMRT, when the gantry takes the position of a field 1, first the segment 1 MLC will take the shape of a segment 1, the beam will gets on. Once the beam radiation dose is delivered by this segment, the beam gets off, and the MLC will take the shape of a second segment. Again the beam will on and beam is off. Then MLC will take the shape of segment 3. MLC will take a shape of segment, beam gets on, and once the dose is delivered, beam is off. The same process will repeat, and gantry will rotate to the second field. Again the process will repeat in this way. Same. Then gantry will take the position of third field and segments will be delivered. So this is the this is the process of step and shoot IMRT. MLC segmentation is performed by optimization algorithm, which we will discuss. Now dynamic MLC segmentation. Now this is the what happened in dynamic MLC segment, because the term dynamic in this technique, if you will see that this is a case of prostate and this is our area of interest, and 1, 2, 3, 4, 5, 6, 7, this IMRT is of 7 field IMRT. Now I will take a one gantry angle. In one gantry angle there are 1, 2, 3, 4 segments. So in this case the MLC is continuously taking this shape of all 4 segments. It means that the beam is continuously on, beam is on state, MLC taking this shape continuously without stopping. MLC is continuously taking shape. This is called the dynamic motion of MLC. In this way you will get a dose distribution. So you understand the beam is continuously on in a particular field, MLC is taking all segments shape and delivering the dose. Similarly for the other gantry angles, MLC will keep continuously moving while beam is on, and in this way your dynamic delivery of treatment happens. The step and shoot IMRT dose delivery is much higher as compared to dynamic delivery technique. For an example, suppose there is a head and neck case. If it is a 7 field IMRT with step and shoot MLC, it will takes around 20 to 25 minutes, and if it is a dynamic MLC, it will take around 10 to 12 minutes. So this much is the difference of dynamic MLCs. In dynamic MLC you can also achieve a better dose distribution. Now I said you that optimization, because all these segments, this is called a segment, this is called a segment, this is called a segment, the shape of MLC is called a segment. This process of segmentation is not performed by the medical physicist. This is performed by the optimization algorithm. Why I said that, I have shown you in 3D CRT technique, when we were performing a field in field technique, what happened, we have created one more field which was sharing the dose of an existing field. So ultimately, with the help of MLCs, we have created a segment. That segment was manually created by a medical physicist who performed the planning. But in case of intensity modulation radiotherapy, the process of these complex segments, because each beam angle have a number of segments, depends upon the complexity of a plan. Each field can have a 10 to 20 or 50 or even 100 segments in a single field. So this process requires a high mathematical calculation, which is generally can be performed and by a computer system, and particularly an optimization algorithm. So what happened in optimization algorithm? This is an optimization window of a eclipse treatment planning system, where you can see that this is a dose volume histogram. This is a preliminary form of a dose volume histogram, where we decide our objectives. In this optimization algorithm, we decide the objectives. So what are the objectives? Suppose here we have a PTV. Now this is a rectum, this is a organ at a risk, this is a organ at a risk. Okay, now this is our PTV. This is our PTV. What we define that minimum 95% of PTV should receive 100% of dose, and maximum 107% of prescribed dose should not receive more than 1%. So in this way, define the objective for the planning target volume. We have defined the objective for this rectum structure, that here we can see that here we have defined the objectives that rectum should receive a minimum dose, and in this optimization window we define the priority. In optimization window, our priority is the target or PTV. We have to achieve the maximum dose to the PTV and minimum dose to the OARs. So our primary objective is to achieve a maximum dose to PTV, and these are the other tools which generally help in the optimization. So it is just for your understanding how optimization window looks like. This is the and all this calculation is performed, all this optimization is performed in background by iteration methods by the algorithm, optimization algorithm. Okay, once your optimization algorithm performed your dose, means once the optimization is completed, you need to perform a dose calculation. So in a eclipse treatment planning system or in any planning system, the optimization algorithm and dose calculation algorithms are totally different. The role of optimization algorithm is to generate a photon fluence for planning target volume and photon fluence for organ at a risk. Means because optimization is nothing the process of forming a small segments. So optimization algorithm is also different for optimization and dose calculations. So once you have achieved your desired objectives in this optimization window, you need to go for the dose calculation. In optimization, I said you that this optimization perform only photon fluence. So this photon fluence needs to be converted into the dose distribution. For dose distribution, the independent algorithm is required, that is we call it dose calculation algorithm. In case of eclipse, the optimization algorithm named is a pencil beam convolution, and dose calculation algorithm is a 888 anisotropic analytical algorithm. There are some more advanced algorithms also there, and depends upon your planning system exists in your institute. So in this way, once you have completed your dose distribution, once you have completed your optimization, you need to go for your dose plan evaluation. So once the dose distribution is achieved and you have gained your dose volume histogram, the process of plan evaluation performed by radiation oncologist or a treating doctor and they generally the choice of their plan evolution is slice by slice dose verification and with the help of dose volume histogram. Before that, I will show you that how the conventional your IMRT can achieve a better OAR sparing and high therapeutic gain. You can see at this picture, in conventional technique your OAR cannot be spared. In conformal you can spare little more, and in IMRT you can spare much more. So this is the difference between IMRT conformal and conventional, that you can spare a very well in. Now one more advanced form of a intensity modulation is the volumetric modulated arc therapy. It is a technique also termed as rapid arc, is a highly complex treatment technique in which 3 simultaneous variation of gantry, rotational speed, MLC speed and dose rate. So volumetric modulated arc therapy is a kind of intensity modulated technique with more complexity. What complexity is involved in this technique? There is a simultaneous movement of a gantry speed, MLC speed, as well as a dose rate. In IMRT technique there is a no dose rate variation, but in case of VMAT technique there is a dose rate variation. Now look at the figure. In IMRT technique you have to enter the number of fields 5, 7, 9, 11. But in case of VMAT technique, there is a full freedom of all 360 degree around the patient. It means that even because it is a arc technique, once the gantry start from 0 position, it continuously rotate around the patient either in a full arc or in a partial arc. So what happened in this technique, there is a full freedom that at each angle there is a modulation. Each angle there is a modulation. It means that there is a marginal increase in the segmentation. There is a marginal increase in the degrees of freedom. So there is a higher modulation. Higher modulation means higher segmentation. So VMAT technique, when VMAT technique generally forms a sector, and according to the sector the segments has been formed. In this technique, as I said, that full 360 degree freedom is utilized. Number of control points depends upon the complexity of plan. As I said that you have a choice of all 360 degree. So each segmentation for each degree we call it simply control point. So higher the control points, higher is the modulation, better is the conformity, better is the OAR sparing. I will explain you how the VMAT treatment delivery takes place. Suppose this is your patient and arc is like this, from arc here to here there is a complete full arc. What happened in this technique, there is a gantry rotational speed. In IMRT technique gantry is static. In rapid arc technique the speed of gantry depends upon the segmentation at particular angle. If at a particular angle the number of MLC segments are more, the gantry speed decreases. Your dose rate also decreases, means decreases, and MLC speed also vary. So depends upon the number of segments and the size of a segments. Please try to understand the size of segment is also important. When you have a very complex plan where you have to spare a very small organs, or you have to spare a organ which is in a very near to the target, the degree of conformity, to achieve a degree of conformity, MLC needs to form a very small segments. That segments and small segments as well as higher number of segments at that particular angle. So for that segment the MLC gantry speed needs to be reduced, and the MLC movement needs to be also adjusted with the dose rate. In this way the variation of gantry speed can allow you to deliver a required dose to the particular area of interest. Now, what is the benefits of this VMAT technique or this rapid arc technique? The most important benefit is the reduced treatment time. It helps to reduce the intrafractional patient movement. As I said you that the step and shoot IMRT for an head and neck case generally have a treatment delivery time to 20 to 25 minutes, whereas dynamic IMRT have a treatment delivery time of 10 to 12 minutes. Whereas in case of VMAT technique, the treatment delivery is almost 1 minute per arc rotation. Means suppose the treatment is delivered by a single arc, the maximum treatment time is 1 minute, and if the delivered by 2 arc, it is 2 minutes. So the treatment delivery time is drastically reduced, and it has a advantage. Intrafractional patient movement can be well reduced, which increase the dose delivery accuracy. The second benefit is that less number of monitor units as compared to IMRT technique, where the number of monitor units has been more. The MUs by rapid arc technique is almost half or near to half. So less number of monitor units means that less toxicity or higher degree of conformity. The conformity with VMAT plan is well improved against the IMRT technique and highest degree of homogeneity. The thing with the VMAT technique, the disadvantage of VMAT technique is that the integral dose, because the radiation is delivered throughout 360 degree for each degree, the integral dose is also increased. So this is we explain means this is our topic which is going to complete about. In short, I will explain in summary form that what we have learned today. We studied what is mean by intensity modulation and how intensity modulation is achieved. Intensity modulation is achieved by the movement of MLCs and movement of MLCs and formation of number of segments. And this segment formation is performed by a computer controlled algorithm. That is, there are, I said that, two algorithm, optimization algorithm and dose calculation algorithm. After that, we understand that arc technique is also there, which is in arc technique there is the same process of intensity modulation is performed, but in this technique there is an addition of movement of gantry rotational speed, variation of dose rate and the MLC speed. So finally I want to close and thank you very much.